Welcome to the final day of Health Promotion and Disease Prevention Track. This morning's presenter is Cameron Chase, a health director from the Tunica-Biloxi tribe of Louisiana, presenting on how health promotion and disease prevention behaviors have changed during COVID-19, a frontline perspective. Cameron's diverse background in clinical biochemistry, public health, education, and 6 years as a senior evaluation specialist at USET have uniquely prepared him to lead the creation and development of a community health clinic at a tribal nation in the midst of a global pandemic. Welcome, Cameron.
Thank you, Alexis, and thank you, USET, as well as everyone else who is spending their time today to listen to me speak. I would also like to have some discussion generated for those who are paying attention, so feel free to ask me questions at any time. Before we get started, I know the title of this track is Health Prevention and Disease Prevention, right? Health Promotion and Disease Prevention. And that was a really long title, so I just said health behaviors. We are focused on health promotion and disease prevention here today. Again, my name is Cameron Chase, and I am the health director at the Tunica-Biloxi tribe of Louisiana. My personal background, just a little bit about me. I'm Filipino and I grew up in Seattle. I've also lived in 4 different countries, 7 states, and speak 4 languages on the violin. I like to do these kind of personal backgrounds just so you kind of understand my perspective and where I come from. Professionally, after college, I taught middle school and high school math and science for 5 years, and that was really formational and a good foundation for me understanding what service was and what was needed. Also, I liked to do, and it drove me towards public health. And at the beginning of my public health career, I was able to found a rural health organization in Guatemala supporting a local health promoter model focused on maternal child health, basically getting lay health people to support one another with proper health beliefs, particularly around family planning and pregnancy support and prevention within the right birth spacing periods, as well as providing healthy resources for new mothers as well as families, including fathers. After that, I went on to USET to serve as the evaluation coordinator and senior evaluation specialist at USET for 6 years. Go USET. I greatly enjoyed my time there, and that led me into my next step, which was becoming the health director of the Tunica-Biloxi tribe since last October. I also have my education. The health challenges. We're going to characterize known health behaviors known health behavior changes attributed to the COVID pandemic, discuss the impacts of these behavior changes within American Indian, Alaskan Native communities, and then share a frontline approach to addressing these COVID-19 challenges and impacts, specifically the ones within the community that I serve. So the first one is the first objective is these key challenges. These key challenges are broken up into several categories. The first one is social. For social challenges, we have, of course, the global changes with people not going anywhere. School, government, business, everything is closed. So you have to work from home and have virtual closures. Unfortunately, that means there's going to be a reduced development of learning and development opportunities. And that's particularly for children. So that's why I put child in there, just because they're the ones who are disproportionately affected as an age group. Of course, there are other groups, those who don't have access to technology or spare income, or they have to choose between being healthy, going to school, or going home and shutdowns. We also have increased disparities amongst marginalized groups, populations, particularly by race, gender, income levels, and there's overt prejudices such as anti-racist sentiments against Asians and Asian Americans, within the United States, as well as globally. You also have an increased poverty, food, energy, and housing insecurity rates. People don't have this clear or easy access to food or stable housing, or can even pay their light or energy bills. And that kind of segues into the economic challenges. There's increased under and unemployment rates, interrupted supply chains and commerce, which are affecting people's daily lives, particularly within food and travel. There's also accelerated transfer of wealth to the richest individuals and countries. The United States has definitely suffered, but probably benefited more than most other countries. And the data do show that to be a pretty clear trend. Additionally, there are the political challenges, of course, the politicization of health information and facts, closure of international borders, and increased border security or insecurity, however you want to define it. You also have increased trade restrictions, increased strain on political diplomacy. And I put this all out there to put the context of these health challenges. The excess mortality, morbidity, and comorbidity rates have increased. There's an estimated 2 to 3 million COVID-related deaths since 2020. And the reason why that range is so large is because we don't know all the deaths that were related to it, because we don't have an accurate way of measuring it, as well as the comorbidities that could be a result of COVID, whether it is isolation or depression, or suicide, or other comorbidities such as hypertension, or people who have pulmonary or immunocompromised diseases that COVID was able to take advantage of. There's also social isolation, increased domestic violence, mental and behavioral health issues. And then when you look at the overall public health systems and infrastructure, innately that means that when the health system can't meet one need, it probably can't meet all or many other needs, such as cancer patients needing ICU treatment beds or ECMO machines because they're all up by COVID patients and there's no more ventilators, or people who need a transfusion in an area that is no longer available because it's overrun with COVID patients. At the front lines, at the very beginning of this pandemic, we had health providers, nurses, doctors literally deciding who gets to live and who doesn't. And so I talk about that in all of this context, to kind of give a global view before I get to the tribal view of what's been happening at the local and international levels and how they impact one another. And ultimately, that's just reduced access to care. If you want to sum it and boil it down to one main cause of the challenges of COVID-19, is there is a clear selection bias for those who have resources to pay for healthcare and those who don't. And while some of it's anecdotal, there is a lot of data out there that is being shared in research and is proving to be true. So let's look at the known health behavior changes as a result of this pandemic. All of this is supported by research. So I have citations at the end of this presentation. And the negative behavior changes that we've seen quickly are increased substance abuses of alcohol, commercial tobacco, and other illicit drugs, decreased physical activity at large, decrease in access to safe environments for physical activities, increased sedentary behaviors, decreased difficulty achieving healthy eating and body weight goals, reduced access to healthy foods, stockpiling food, stress eating. They're all factors that have contributed to this, but are related to the negative behavior changes. You also have increased rates of psychological distress or psychiatric disorders, such as anxiety, depression. I'm sure there's more, but there's not a whole lot of published research out on that right now. But there's a lot of increased domestic abuse and interpersonal violence rates. But there have also been some positive changes. Those positive behavior changes do include increased social distancing and hygiene behaviors, obviously. I mean, when we look at the flu rates, the flu has gone down dramatically. There were hardly any, there about 5% the standard infection rate, morbidity rate rather. And a lot of people attribute that to social distancing. Some people misinterpret that as it doesn't exist, or some people said, oh, they just called flu COVID, but there's no discernible or definitive information to prove that. All of the flu and COVID numbers have been proven with tests. Additionally, positive behaviors include social integration of families and communities. Because of COVID, you have globally a lot more integration, and you can think a lot of that to technology, which is a double-edged sword, but you can also think it to people just checking up on each other and a global sense of awareness of their neighbor, of their community, making sure that we're taking care of each other. Yes, the media does show a lot of ugliness and it does exist, but research is showing that there is an increased integration within communities, even though the cost of this pandemic, as earlier stated, has been reduced developmental or social interactions particularly for children. So I want to contextualize, then some other behavior changes that we see that have mixed results, some positive, some negative, are public engagement in science and medicine. You have an increased knowledge of virology and particularly epidemiology. People know what epidemic is, and they now understand there's a whole study behind it. And they're starting to understand, they can explain to you what a retrovirus is and what a viral envelope is, and they can get into the biochemistry, signaling pathways. They even know what mRNA is and how long it lasts and what it means. And they understand the central dogma of biology between transcription and translation, and how this novel vaccine works. Now, it's not everybody, but I would say globally at large, a lot more people definitely have learned more about science and medicine. But at the same time, there's been a large distrust or even just blatant disregard of medicine and science, which has resulted in lower risk perception of not just COVID, but diseases at large, particularly infectious diseases. And a lot of that is in the younger population, a lot of the research is showing, but it is also pretty ubiquitous amongst most age groups. The one age group that I would say, both in my experience and through what I've seen in literature, is that the older age group, 65 and older, and within my community, 55 and older, they're a lot more aware that the medicine and science, and they're not as quick to distrust or disregard it. They usually engage in it a little bit more, and they contextualize their opinions. Sometimes they do come to an incorrect conclusion, but for the most part, they usually follow along what's accurate. Then there's also the use of technology, which again is a double-edged sword. You have increased telehealth utilization rates. You have increased people who are connecting through screen time and use of social media. But the challenge with that is, again, undoing the damage of disinformation or misinformation campaigns, which do exist. And I'll talk a little bit more about that later. But ultimately, technology is great when used properly, but has some negative challenges. From a behavior perspective, you're still able to connect in the middle of isolation, but then who you connect to can often be determined by an algorithm if you're not properly connecting with people you already know. And if you were already socially isolated before this, it exacerbated significantly. And one weird change is changes in quality and quantity of sleep. There's not enough research out there for us to truly understand or know what is causing these changes, because I think you need to stratify more by different factors, determinants such as class, race, age, maybe even gender. But I believe that changes in quality and rest of sleep are pretty indeterminate right now. You do have some people who do get better sleep. They're just getting better sleep because they have more time on their hands. But I also believe that there are selection factors and criteria for that. Gender, violence, age, income level, all these things probably have a pretty strong influence, but there is no discernible data out there. And I don't want to make any irresponsible conjectures, but I would imagine that all those do have significant impacts, that we could probably propose some causes within our own populations, and particularly tribal populations. So contextualizing all of these behavior changes, I wanted to also discuss the impacts within American Indian and Alaskan Native communities, and compare that to what we see at large in the general populations. travel impacts that we've seen during the COVID-19 pandemic, American Indian and Alaska Native populations have experienced disproportionately less access to health services and resources than the general population. This is also true for related health determinants such as access to healthy foods, areas for safe physical activity, and access to transportation services. And this isn't much of a surprise. We kind of already knew these sort of things. We've seen this in other emergency situations, not just pandemics, but the research does corroborate that this is continuing to occur. However, COVID has also increased community dependence on technology. As I had already discussed, the dependence on social media and electronic communications has increased, allowing people to have greater access to services such as telehealth. This transition from everyday in-office life to platforms such as Zoom and high utilization rates of groups of formats such as Teams and other options out there has grown the virtual world for everybody from age 2 to 192. Well, maybe not 192, but my point is everybody who knows how to use technology has increased their ability to connect with individuals. And so providing online electronic health supports to Native American populations can also serve to reduce these disparities in access to health resources. I would say one caveat to that is that most Native populations do live in rural, non-urbanized areas with a digital divide. There's not a lot of access to high-speed internet or reliable internet sources. So that's definitely something to continue focusing on and take an opportunity to address. Some other impacts that I want to contextualize are behavioral health. The COVID pandemic has also seen a disproportionate increase in adverse behavioral health outcomes within AIAN populations. You see increased rates of anxiety, depression, interpersonal violence, substance abuse, self-harm, suicide ideation, and attempts. These have all increased during the pandemic, and they have decreased disproportionately within the AIAN population group relative to the general population. So there are disproportionate increases that are cause for concern. There's also social isolation through quarantine shutdowns and stay-at-home orders that seems to be a primary risk to these poor behavioral health outcomes, which again isn't a surprise. When you isolate an individual who's already at high risk of behavioral health issues or higher or elevated risk, they run a greater risk of this constellation of health issues. Conversely, though, as I stated before, there's an increased social integration of families and communities during the pandemic. So providing community programming and supports that take advantage of increased social integration could safely reduce social isolation. So in the middle of an outbreak, when you need to have your yoga class, you can still do it online. You can have people who know how to utilize social media or marketing tactics and techniques assist with providing online health information or classes or programs. And that doesn't necessarily mean it's got to be in the confines of your home. You can record it and put it, or time, you can record it and put it on a YouTube site or on Facebook or Snapchat or wherever. You can put it on anywhere that has a TikTok. You can utilize these social media platforms for opportunities to start health trends within your own community. And a side benefit, which I don't think there's been a lot of research on, but I would imagine that there's an intergenerational connection between those who are more adept at using technology and teaching other generations how to use that technology. I myself am a millennial, and I know there's a lot that I don't understand that I can learn from both the older and younger generations as we all learn to navigate this together. So again, online electronic health supports could synergize not just the increase in social integration, but an increased adaptation of new health and social technologies. And this is kind of the touchiest subject that I seem to find around travel impacts, and that's the politics and medicine. The science and medicine of COVID-19 has been highly politicized, particularly within the United States. Not to say it hasn't elsewhere, but it's strongly been done so. It's strongly been politicized in the United States. Politically motivated misinformation, disinformation, bias reporting, and lies, straight up lies, have perpetuated unsafe behaviors, such as the unprescribed use of ivermectin, not wearing masks in crowds, regardless of vaccination status, or mixing vaccine doses. I mean, I could go on with vaccine hesitancy and many others, but these are just simple examples of where political use of medical and scientific information is causing harm to the general population. And this misinformation is often perpetuated on social media and within social groups. So the way to address it is probably having a direct line of communication. And because tribal nations have that direct line of communication and are generally trusted by the tribal citizens, health education and information campaigns should be utilized to combat misinformation and increase scientific and medical knowledge around the COVID-19 pandemic. So some key objectives that we've covered so far are identifying the challenges, the known behavior changes attributed to COVID-19, and the impact specifically within and how they affect AIAN communities. With that context, I would like to share the frontline approach that I have taken as the health director, as well as my tribe and individual citizens within the Tunica Biloxi tribe. But also some of this is contextualized, can be contextualized by my time at USET, having worked with many different tribal nations, and some of the individuals that I've worked with are on this call. They've, when it comes time for discussion, I'd really like to hear your input as to what your experiences have been, because, well, I can't share them for you. I have learned from them, and as we go through them, please feel free to interrupt or ask any questions or interject with what you have done. I want the rest of this to be kind of more of a discussion rather than a lecture. So on the front line, we've used an ecological approach. So this is a picture of the ecological model, basically looking at different levels that issues can address, can impact individuals and their health. We're going to go from the larger level, from policy down through individual. So, and we're going to group some together, but starting with policy, supporting policies and procedures that we've worked on, the Tunica Biloxi Tribal Nation did not have an emergency response team or ever, of course, a pandemic or COVID response. So we have specific COVID safety protocols for masking, testing, quarantine, contact tracing, vaccination, travel visitation, emergency shutdown, telework, etc. We now have COVID policies for all of those. However, we also now have emergency response. We have an emergency response team that and policies where we've established or in the process of establishing a list of priorities and procedures during many types of emergencies. That could be inclement weather. I kept thinking like fires and floods, and that's all weather related, but terrorist attack, gunmen, stuff like that. And we do have some of those policies, but we don't have them as a community knowledge at large. So these are things that we can work on expanding, and that's what we are doing. We also have health policies that have been updated. We've increased some of our administrative policies within our health department and for the tribe. We also now have clinical infection control, more health information management policies, information technology policies, person referred care and safety policies. And a lot of that comes in the context of some other changes that I'll go through, but long story short, the tribe did not have a clinic before, and during the pandemic, we've used this opportunity and funding to be able to expand our 638 contract beyond just purchase referred care. So when I talk about administrative, clinical, infection control, and all these different policies through the health department, those are new within context to not just the services, but also to the clinic and other infrastructure that we are growing. And that's that next level, that institutional assistance approach. We've formed that pandemic or emergency response team, and part of that is supported by creation of a public health director position. We've never had a public health director. And even at the beginning of the pandemic, we didn't have a health director. We were without a health director from September 2019 until I joined in October 2020. And in that time, the tribe had chosen to expand their 638 contract from purchase and referred care to being a tribally operated 638 clinic, meaning that they can use their IHS funds to open their clinical services. And as the health director, I have led that with the support of many different staff and contractors. I have not done it alone, nor would I have been able to. So I want to give credit to all of our great contractors, council staff, community members, and administrative team who have put together a lot of time and patience in understanding what is needed to open a clinic, particularly in the middle of pandemic. This is something that has been it's kind of been, there's been a good side and a bad side to it, double-edged sword, so to speak, in that, yes, you have a pandemic, so maybe you can control your volume and how you come into your clinic a little bit more. But when you do get people, the cases can often be a lot more acute, and the challenges of infection control are a lot higher than normal. So this is a kind of trial by fire, drink from the water hose, whatever metaphor you want to use. But again, I attribute that to the incredible capacity of our tribal nation. One of the challenges that tribes don't often have is the opportunity to prove themselves. It's not that they don't have the resources. It's not always that they don't have the people or capacity. It's sometimes they just don't know how, or they're not given the chance to prove themselves. And I think that at the Tunica-Biloxi tribal nation of Louisiana, we've been able to address that, and we've met that, maybe not with flying colors, but we've learned a lot from it, and we've built a lot of capacity. So that includes our COVID-19 services. And initially that was just testing, that grew into vaccinations and PRN care for COVID treatment. PRN, basically Latin for as needed. So as people needed COVID treatment that we could provide, that we knew how to provide, we were able to provide it. And that also means that the opening of an ambulatory clinic. In May of 2021, we opened our clinic to community members. And that was about just under 6 months from the time I had started to opening the clinic for community members for ambulatory care. However, with the COVID spike locally and within the tribe, we unfortunately have had to put those services on hold. Though they're not being reduced necessarily, we can't provide both that and keep all of my nursing and clinical staff safe in the middle of a pandemic, while also opening an ambulatory clinic. So because our COVID services are kind of the last line of defense and the only testing that many people have access to, we have reduced our clinical services, ambulatory care services. However, we do have telehealth services. So when people need PRN care, particularly around COVID or any other issue, we can provide those telehealth services or refer them out. They still have that option for person-referred care. So while we do have a tribally operated 638 clinic, we also do operate with person-referred care to supplement. And a lot of that supplementation has come through CARES-related, COVID-related funding, through CARES, FFCRA, ARPA, all of the congressional COVID funding that Indian country has received, we have had access to, and we are utilizing to meet that need and bridge that gap. Additionally, we've integrated our behavioral health and social services programs with the ambulatory and healthcare programs to provide full wraparound services for all health needs of the community, or of community members. And what I mean by that is that we've never really had a health clinic or a health department with clinical services. We've had a health department that referred clinical care out, and had a diabetes coordinator that also provided elder care. But beyond that, we never had behavioral health department. We had a social services program that had a behavioral health grants, such as opioid funding, other SAMHSA grants for tribal behavioral health programs, but those were under the social service department. And now with the opening of a clinic and the expansion and increase of not only like the capacity of our department, but of the staff in our department, we now have the ability to integrate those services with the social services department and allow the behavioral health staff to operate on their own. And once we have a better integration and expansion of services, our tribal administrator and council will decide whether they would prefer to have the health department as a standalone or remain under social services or move to the health department. So those are the three options that are being weighed and depend heavily, I imagine, on the success of the clinic and the expansion of our capacities. In addition to that, we also have an expansion of new and existing partnerships and resources with IHS and other federal agencies. Of course, as I've said, other federal funding, the state of Louisiana, local hospitals and tribal nations and local businesses. One of the things that we're working on is trying to take advantage of our relationship as much as possible, such as 105L leasing. That's something that if you run a tribally operated 638 clinic, you should be applying for as much as you can from IHS, because there are funding sources that aren't guaranteed. You have to go through and actively apply for them. But it's a caveat of a double-edged sword where you may be a new clinic and you may be able to have all these resources, but you need people to actually do the program. So as you increase these programs, you need to increase your staff and their capacity and availability. So those are stumbling stones that typically we have to overcome. Some other approaches that we've used are expanding our community programs. So for example, we created an e-COVID response team using a lot of the funds from the CARES Act. And we just repurposed our opioid response team to serve that dual role, of course, of staying as an opioid response team, but also being able to provide support through COVID for behavioral health issues and non-behavioral health issues, so health at large, as a way to stay in contact with high-risk populations. We've also adapted our elder and SDPI outreach program to include our COVID program. So any COVID PRN care and outreach, when somebody's positive, we add that to our SDPI and elder care program, or Q. We also have expanded our transportation program to include any COVID-related medical or social assistance. We also have catastrophe assistance programs for food, housing, and energy insecurities. We've also expanded availability of purchase and referred care funds to assist with COVID-related medical care, expansion of the language and culture revitalization program to include apprenticeships for tribal youth. What I mean by that is we have an education department that has a cultural component for revitalizing culture and language particularly, but because particularly youth have not been as engaged because of virtual schools or because there's been a lack of interpersonal time for them to connect with people their own age or really anybody at all, our education department has expanded their resources to provide an apprenticeship program to allow them to, one, be busy and do something, but two, do that proactively by integrating with culture and identity. And at a young formative age, that's not only really important, but that's an opportunity to extend the life of your culture and expand the and to expand and rejuvenate the maybe some of the lost practices, customs, and identities within your own community. Again, that goes back to even the intergenerational connections of that we saw as some of the behavioral health changes or the other health and behavior changes that we've seen previously. And then, of course, we have a PPE resource program that is run by the new public health director. So these are the community level programs that we have directly implemented with the aforementioned institutional and policy changes. I also want to state that, well, we haven't fully been able to expand it. That's the next slide, sorry. We've also, I'll skip ahead, I guess. We've also expanded our education and health information campaigns and resources, and that's included a lot of electronic resources and announcements. And as I mentioned before, use of YouTube, social media, Facebook, those are all areas that we are working on. Focus has been primarily on a website Facebook and email campaigns, but we also are looking to expand into TikTok. And of course, we're trying to get council approval for those sort of things, but they, it's sensitive. These are sensitive issues in a sensitive community. So we have to do it with council approval and understanding of what's being done so that no harm can be done. But we also have, of course, the vaccination and testing program that I mentioned. And then, and this is this third bullet here, capacity building opportunities for community members and employees around infectious control, disease control, epidemiology, and COVID-19. Again, this goes back to the education campaigns of the second bullet, and just letting people understand and giving them the opportunity to understand what a degree program may say, oh, this is really complicated, but in reality, is not that complicated if you break it down into the simple parts that you still learn in that same degree program. So when you give your tribe or your community the opportunity to truly engage in the actual science and speak from a place of respect, regardless of whether you agree with them, regardless of whether they're accurate in their view, if you speak and come to them from a place of respect, oftentimes they'll listen to you too. And if you can share from a shared experience, there's oftentimes they're going to be the ones who finally agree and understand that what was told to them before is not true. For example, microchips in a vaccine, or the vaccine's not safe, or the Johnson & Johnson vaccine caused a lot of deaths. No, it caused complications in about 7 different people when that was related to blood clotting, 7 out of 7 million. So that's better than Depo-Provera shots. And those are already FDA approved. So when you talk to them from that perspective, and you share that information, you ask them questions to clarify what their understanding is, they usually have a better understanding. And especially in staff in leadership positions, that's the place to start, because they're the ones who are leading their community and people look up to them as well. We are also expanding our Medicare, Medicaid, and health insurance enrollment campaign. Before, again, we were focused just on the elderly and STPI or diabetes community, but we are trying to expand that to everybody. And that's not just tribal citizens, that's anybody within our community. If we can assist them in applying or getting health insurance through the process, we will do it. Now, for non-citizens and those who aren't eligible for our IHS purchase deferred care or any other non-existing program at this time, we can't assist financially, but that is something that we will look into because we believe that if we can increase access to healthcare, regardless of how that is done, it will reduce the cost and burden of not just COVID, but all diseases. The key takeaways from this pandemic so far, and I mean, there's many more, but the strongest ones is that behavior change takes time. You got to keep perspective because, just as an example, vaccine hesitancy is most often, I've seen it overcome just by positive first-person interactions. When somebody's uncle, cousin, and best friend all finally get vaccinated and they're all okay, they realize, oh wait, no, this isn't such a bad deal. They start looking into it with more of an open mind, and they start to realize, hey, this is the greatest phase 4 trial we've ever had. We've never had better data for an experimental drug in the history of humanity, and we may never again. And when you keep that perspective of one person at a time, those small victories do add up. And it's not always just with individuals. It could be with leaders, it could be with organizations, it could be with entire groups, such as working with elders or youth and getting them to understand how your services work or what your goal is. And I think that kind of bleeds into the next one, that true change requires a team approach. You have to be respectful of one another, and you can't just dictate what you think is going to happen. And the devil is in the details, policies, and consistency. In order to back this up, you need to have a policy that you can consistently implement and overcome, because that will help you overcome most pushback or political ill will. And particularly in tribal nations where politics can have a stronger impact, you generally need to have that political side. You have to have your council or elders or influential community members on your side. So That's all that I have to go into great detail for today. Again, my name is Cameron Chase. I'm the health director of the Tunica Biloxi Health Center, the Tunica Biloxi Health, Tunica Biloxi Tribe. And that's my email, cchase@tunica.org. And my phone number is 318-359-3659. Feel free to call me, email me, text me. And I do realize that we have a little bit of extra time. The citations I came up with, but if we finish, I kind of wanted to propose these discussion questions. I didn't know if we would have time, but basically these are the objectives I talked about, but I want to hear from you. What are the challenges that you've had? And if anyone wants to share, please raise their hand and we can go ahead and engage in a discourse of what you've seen within your tribal nation or community. It looks like while I'm waiting for people to speak up, I have a question from Yvette. Do you currently have a plan for safe use of TikTok? If so, can you please describe that? Thank you. That's a great question. And that's one of the reasons why we haven't yet gone through to TikTok, is because there are safety concerns that we are still trying to evaluate. We don't have a full plan yet, but we are working on building a social media policy that includes considerations for platforms such as TikTok.
Would you be willing to share that once you have them?
Yeah, of course. I can share that. I can share that with USET once we have it, and we'd be happy to share that with you. I don't know when we will finish that, but that is something we are looking into. Thank you, Yvette. And you can feel free to email me as well.
Thank you.
Jason.
Hi, Cameron. How you doing?
Good. How you doing? Nice to hear from you.
Good to hear from you as well. So listen, first I just want to say excellent job. I am so proud of you. It may sound silly, but I'm so proud of you, man. Excellent job. I love what I'm seeing. I didn't realize you were taking something basically from the ground up and building it. And so tremendous job. One of the challenges, or one of the basic challenges that we've faced here at Shinnecock as a result of COVID-19 initially was the fear of it. I can remember when it first happened, I didn't even want someone to come down my driveway. That's how scared we were. And then at the same time, we were trying to create these programs to support, not programs, but these situations where we were still trying to take care of our elders. We were still trying to provide people with food. We were still trying to find ways to communicate with people. We went from being an extremely social tribal community, as all are, to now trying to find a way to contact people and talk to them and do it in a safe way. We had to figure out, we had to create a response team. We had to figure out, how do we reach out to elders and those who do not have social media? How do we do that in a safe way? How do we were using gloves and writing on pieces of paper with gloves in hand, putting that in a plastic bag and hanging it on people's doors so they wouldn't get sick. Like, we just went through a lot of learning and trying to figure out this stuff on our own. And then at the same time, we had to deal with what you hear in the media. So you have one side that says, "Ah, man, this is fake. It's all made up." And so you have people, maybe I'm in New York. For those that don't know, we were the epicenter of this disease when it first hit the United States. And so, although we're about 100 miles away from New York City, that's close. That's basically our backyard. So, we're watching on the news, and there's so many people that were dying from this disease that they were doing mass graves. And then I have friends, cousins, relatives, other tribal friends from other parts of the United States that are like, "Oh man, this thing it's not even that bad. People are, does anybody know anybody who's died? And I'm like, well, yes. I mean, I do. I'm watching it every day, and we've lost tribal members from this disease. So it's very real. Please take it seriously. And we were, kind of screaming at the top of our lungs for, I don't know, a good 5 or 6 months before I felt like even the rest of the country or world even realized that there was really a problem. So we learned a lot during this pandemic. And one of the things that worked for us was our social media presence and footstep that luckily we had just barely started before um, COVID really kicked off. So we had the opportunity for a handful of people to get involved. And then what happened was, prior to COVID, I was trying to explain to other directors and departments, hey, listen, you should have a presence out there in social media. And a lot of them would say things like, well, like our information, like say, for example, travel enrollment. One of their things was, well, our information is so sensitive, you can't just have it out there in social media. And I understand that, but not everything is sensitive. Like if someone has a question, there's common questions. What do I do to get started to get enrolled? How do I enroll my newborn baby? Those are things that you can share on social media. Those are things where you say, well, come down to our office, you're going to need a birth certificate, blah, 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 whatever. That's not so just giving that information isn't so sensitive that you can't put that information out. So we had a lot of resistance. Then COVID hits. Then it's hard to talk to people. Then it's hard to get things done. And then directors, other tribal friends that I have, people were coming to me and saying, hey, how do I set this up? How do we do this thing? We need to get this information out. So I'm glad I was able to help in that way. And I'm glad to see that a lot of our tribal departments kind of got on board, even our tribe as a whole, like from our leadership down. Our leadership went into having, how do we have our tribal meetings? Like we're not getting together. And so they stopped for a while. And then we were like, well, we could do this in a private, closed environment, and we could do it through, different forms of social media that they use that can be private, invitation only, all these type of things that we have now using Zoom and all these things that we all kind of discovered at the same time. So, all I can say is that that's just a part of our resilience as Native people. We will find a way. We've always found a way. And I'm going to end with saying, Cameron, I'm so extremely proud of you. Thank you for this presentation.
Thank you, Jason. Yeah, first off, you've been an inspiration for a lot of the work that I've done. Watching everything that you just mentioned has been helpful in my genesis of a lot of these programs, not just professionally, but even personally, and looking at the resilience that you've personally shown through this pandemic, as well as professionally, and the leadership that you've shown your own nation. I've had the privilege of working with the Shinnecock Nation for the past, 6 of these last 7 years. And I've learned a lot from the growth of witnessing a recently federally recognized tribal nation grow its capacity. And it's helped me best understand how me as a non-Native person can help assist and meet the needs, but with that humility and understanding that is needed for tribal nations. Because, well, it's really easy to get frustrated at individuals or systems and say, why can't you just do this? It's not that easy. And I sometimes have to take that with myself, because I get frustrated at myself for not being able to get things done, because I have a high expectation and I can't always meet it because of these additional barriers that I characterized earlier in this presentation. So yeah, meeting the needs of elders, meeting the needs of specific community members and groups that are highly marginalized already in the middle of a pandemic. Not to mention, and I didn't mention this at all, but I'm not from Louisiana, but man, the Louisiana people know how to survive. It is ingrained in their blood. When you live on the coast and you are constantly every year, multiple times a year, dealing with all of the natural disasters that occur, you get used to it. And there is a fight in Louisiana and the Tunica Biloxi tribe that I've not seen in many other people. And so that's something that, as I get to know this tribe, that's a benefit that I utilize in my services and in calling upon that in them and their identity as a tribe to help and serve one another before they get upset with each other, and help them understand and be patient with themselves. And so Shinnecock has certainly taught that to me, and in my many experiences working. So thank you, Jason. Thank you to the Shinnecock Nation for the honors that you've bestowed upon me to work with you, from being able to go to your powwows and being able to work with your growing GWIC program, or even watching you build your own clinic and stand it up with your own services.
Thank you.